it blocks sodium glucose transporter 2. That's right, Donald. So if you want, it blocks this sodium glucose transport. And now my question is, what would tubular fluid concentration over plasma concentration look like if I was using canagliflozin? A, B, C, D, E, or F? Your turn. So for this, you have to remember what you saw in your renal module. How does a normal kidney handle glucose? What happens to a diabetic to glucose in a kidney? And further, what would now happen if you block the pump that reabsorbs glucose in the kidney? Tough, this one, huh? You have one chance out of 6 of getting it correct, so that's not too bad. Still better than the lottery. No, you just have to think. What happens to glucose normally? Which line would represent the normal handling of glucose by a proximal tubule? What would you tell me? Zahir, agree. That's normal handling, which is there should be no glucose in the urine if healthy. It's 100% reabsorbed. Is that okay? So is it a chance in the diabetic, one, that you have no glucosuria, and two, that on top of it, in presence of a drug that blocks reabsorption, there would be 0% glucose in the urine? What do you think? Initially I had a couple there, you quickly moved out, and I'm glad you did. So here, there's no way that it's F, because not only diabetic have glucosuria, as soon as glucose in blood is greater than about 200 milligram per deciliter, well, you have saturation of SGLT2. And then you have glucosuria. And here, plus, you've added a drug to block reabsorption. So no, it's going to have to be either A, B, C, D, or E. So most of us, and only a few of us, are answering this one, and you'll see it won't take us long to explain. You going for E, it's not going to be correct. The only one that's going to be correct is going to be C, because of this. Tubular fluid concentration is 3 times higher than plasma concentration. That is like inulin. And in other words, no secretion, no reabsorption. Let me explain this to you. We're gonna do it with inulin. There's your glomerulus. there's your tubular fluid, and of course, your proximal convoluted tubule. And imagine for a second that you have 3 sodium, 3 waters, 3 inulin. So, okay? They're all freely filtered. 3 sodium, 3 water, 3 inulin. By the end of the proximal tubule, there's still 3 inulin. But you remember that about 2/3 of sodium and water is retained. So there would be only 1 sodium and 1 water for all 3 inulin. So look, if I tell you plasma concentration of sodium was 3 sodium over 3 water, it was 1, right? Tubular fluid concentration of sodium is 1 sodium for 1 water, it's still 1. So that 1.0, that's what happens to sodium, that's what happens to water. And that reminds you something big in renal phys, which is if here we are 300 milliosmol per liter, we are still 300 milliosmol per liter by the end of the proximal tubule, because salt and water move together. Contrast now, if I do plasma concentration of inulin, 3 inulin for 3 water. Okay, so it was 1. But now, tubular fluid concentration of inulin, 3 inulin for only 1 water. It now becomes 3. So that TF over P is 3.0. 3.0 represents inulin. It represents something that's filtered, that is not secreted, not reabsorbed. Well, if now I have 3 glucose, and normally all 3 glucoses would be gone, there would be 0 glucose because of SGLT2. If I inhibit SGLT2 with a gliflozin, then I end up with 3 if I block SGLT2. So it makes it exactly like inulin. So that's why it's going to be C. You understand why it was C? Yeah? So by the way, when you look at this diagram, anything where it's below 3.0, you've removed. And obviously at 3.0, there's no secretion, no reabsorption. So can A and B occur? Not for glucose, Maria, because there's no pump to secrete glucose. But you know, many substances are secreted. For example, you know that drugs like penicillins, weak bases like atropine, they're secreted. You know that PAH is used to monitor secretion. Is that okay, Maria? So A and B can occur, but not for glucose. The same as you can have D with things like urea, things like potassium, which are reabsorbed or diffused, but they reabsorb less than sodium and water. Whereas if you are below the line 1.0, then you reabsorb more than sodium and water. For example, glucose, amino acids. So I thought I'd throw a question on this too in there, because you realize obviously a kidney module is filled with pathophys. Now we emphasized a lot acid base, and we saw how tubular modification can occur with certain drugs. For example, canagliflozin blocking the glucose transport, acetazolamide blocking the bicarb reabsorption, and we saw how they can correlate of course, to issues with acid base, changes in other electrolyte. So ask me while I'm making this PDF so that you can have it as usual for yourself. Any questions?